A common misconception for EMDR therapists is that they look at their caseload and they say, I don't have anybody suitable for EMDR therapy. So let's take a look at that. The most important thing in regard to your caseload is case conceptualisation. The EMDR therapist will be examining their caseload through the lens of the Adaptive Information Processing Model, or AIP as we now know it. AIP effectively is doing three things. It helps us to look at the clinical presentation. Let's use the example of obsessive compulsive disorder. The presentation with a person with obsessive compulsive disorder may be a compulsion to wash their hands a certain number of times. It has many elements of magical thinking akin to early childhood, and a person may tell themselves if they don't wash their hands 15 times or touch the light switch a certain number of times, that something devastating is going to happen. Rather than looking at those symptoms, or as we call them in mental health, phenomena, rather than looking at the phenomena as being the problem, we understand these as a symptom of the problem being related to dysfunctionally stored memory networks. And so once we begin to look at the case through the lens that something has happened to result in an understandable disorder, then we can begin to use the lens of AIP to identify suitable targets for reprocessing. Part of that will mean taking a history which allows the person to identify problems in their past. And if they identify problems in their past, then these will be targeted using the standard Francine Shapiro 8-phase 3-prong protocol. If there are more difficulties in accessing the target, tools such as float back or even float forward will be utilised to identify a target. And these are things which you go into much more detail in the trainings. Whenever we begin to look at the psychotic disorders, processing the trauma networks involves perhaps working with voices and parts, which can integrate other methods. And those other methods that are involved can be, for example, voice dialogue work, internal family systems, and the EMDR therapist will use these to identify targets which are acting as dysfunctional memory networks. In other words, traumatic material which is stored in the brain and which drives the pathology. So the problem is not the presenting difficulty. The problem is the trauma which is driving that. So when you look at your caseload, the presentation, be that OCD, depression, anxiety, post-traumatic stress disorder, what you're going to do initially as a clinician is to take a history which is then trauma focused. And by doing so, that should help you to identify hotspots, or what Dr. Francine Shapiro referred to as touchstone memories, that are unprocessed information suitable for targeting.